Okay, you can begin whenever you would like.
The Ohio Psychological Association's Education Committee would like to welcome you to Hidden Symptoms, Child Sexual Abuse and Developmental Disabilities, a virtual workshop presented as part of our 2021 annual convention. OPA is an approved CE sponsor of the American Psychological Association and maintains responsibility for the program and its content. OPA is also an approved CE provider of the Counselor, Social Worker, and Marriage and Family Therapist Board of Ohio. This session has been approved for 1 continuing education credit in ethics. Instructions on how to receive CE credit will be covered at the end of this workshop and are available on our website at www.ohpsych.org. At this time, I'd like to introduce our speakers. Dr. Susan George is an assistant professor in the School of Professional Psychology. Susan has extensive experience working with children and adolescents with acute presentations, including trauma, self-harm behaviors, depressive and bipolar disorders, and developmental disabilities. Dr. George has prior social work experience with juvenile probation, intensive aftercare prevention services, foster care, assessment of juvenile fire setters, and she previously supervised several residential homes for children. She teaches courses in integrative assessment, projective assessment, group therapy, and diversity. Her research and clinical interests include assessment, evidence-based treatment of children and adolescents, couples and family therapy, trauma, sex trafficking, and diversity. Bethany Cooper is a second-year psychology trainee at Wright State University School of Professional Psychology. Her professional clinical interests include neurodevelopmental disorders, trauma, anxiety, depression across childhood and adolescence, and their comorbidities. In addition, Bethany has an interest in assessment and parent training. Bethany is passionate about psychoeducation and how it informs clinicians' work with their clients and clients' understanding of themselves. She recently presented research on trauma-informed care for children with fetal alcohol spectrum disorders at APA in 2020 and developed psychoeducation cards for professionals and caregivers to help educate the community about symptoms and secondary consequences of fetal alcohol spectrum disorders. Addie Jeffs earned a Bachelor of Science in Psychology from University of North Carolina at Chapel Hill. She is currently a second-year doctoral student at Wright State University School of Professional Psychology and is pursuing a doctorate of psychology with an emphasis in children. Her professional and clinical interests include neurodevelopmental disorders, trauma-informed care, treatments for children and adolescents who have experienced sexual abuse, family systems treatments, and school-based interventions for children and adolescents. She recently presented research on the presentation of autism spectrum disorders in females and completed a training on trauma-focused cognitive behavioral therapy. Now it's my pleasure to turn over the workshop to our speakers. Welcome.
Alrighty, so today, myself, Addie Jeffs, along with my colleagues, Dr. Susan George and Bethany Cooper, are going to be presenting on hidden symptoms, child sexual abuse, and developmental disabilities. So none of us have any relevant financial or non-financial relationships to disclose. We are all presenting on a voluntary basis. So just a couple fun facts about each of the speakers for today. So like I said, my name is Addie, and I'm originally from North Carolina. I am a twin, and my favorite game growing up as a kid was Monopoly. Dr. Susan George was originally from upstate New York. In the last year or so, pre-COVID. She did lots of traveling to the countries of Haiti, India, Iceland, and Ireland, her favorite being Iceland. And then her favorite game as a child was Guess Who. And then Bethany is originally from Kentucky. She also enjoys traveling. She has been to China now 2 times and would like to go back again. And her favorite childhood game was Operation. So today we have 3 learning objectives for our presentation. The first one is to be able to determine and identify indicators of child sexual abuse in both typically developing children as well as children with developmental disabilities. The second learning objective is that hopefully by the end of this presentation, participants will be able to distinguish their role in the prevention, detection, disclosure, as well as intervention of child sexual abuse for kids, again, both developing typically as well as the kids with developmental disabilities. And then the last objective is participants will be able to identify and demonstrate effective strategies to use with children who have experienced sexual abuse and are also diagnosed with developmental disabilities, both in the classroom, online, and as well as teletherapy and virtual therapy. So the first part of our presentation will be an overview of child sexual abuse and developmental disabilities. Okay. So before we talk about the intersection of childhood sexual abuse and developmental disabilities, we first need to define child sexual abuse. And there seems to be an absence of a shared definition of child sexual abuse in the literature. One of the reasons for this is because there are multiple terms used in exchange of child sexual abuse across different fields. Some of these terms include child sexual assault, child sexual victimization, child sexual exploitation, adverse sexual experiences, and unwanted sexual experiences. And the main concern is that these concepts differ often across 3 different dimensions. The first dimension is just the definition of the construct of child sexual abuse. The second is the definition of the specific acts that constitute child sexual abuse. And then the third is definitions regarding what is and isn't consent. However, it is really important for the various sectors involved in addressing child sexual abuse to develop a common definition to enable accurate rates of prevalence, case identification, prevention, and treatment. And so Matthews and Colin Vizina in 2019 came up with a conceptual model of child sexual abuse that has 4 different factors that have to be met in order for it to be determined as child sexual abuse. So the first one is the person a child? So this would be that the person is legally under the age of 18 or they are developmentally considered by society as a child. The second one is true consent absent. And the third one is the act sexual? A lot of times definitions can differ in terms of whether it has to be physical contact to be considered sexual, but there are other behaviors such as viewing pornography or viewing a sexual act that can also be deemed sexual, not just the physical contact. And then the last factor is, does the act constitute abuse? And in the next slide, we will be showing the decision tree that they came out with that walks you through each factor and kind of gives you the criteria where, yes, this factor is definitely met. There's also some areas where it gives you like a maybe, where there might be a little bit more of a gray area. You're not sure, like it could or couldn't be. There might be a little wiggle room there. And then there's also rule out criteria for each factor. And then in addition to these 4 factors, there are a couple other things that you also might want to consider when deciding whether or not something is sexual abuse. And that is power and knowledge differentials. And a lot of times that comes into play when it's child on child abuse. So trying to determine whether or not the child who perpetrated the abuse was in that kind of power role, and was there that difference in power between the perpetrator and the abuser. And then also it's always important to determine what system you're working in, because definitions can be a little bit different, especially when in the legal system compared to like sociology or psychology or education. So it's also important to keep that in mind. So this is the concept map. I'm not gonna go into it in too much detail. It's very straightforward, very easy to read, and it will be provided to everybody with the slides show. So the next thing that we want to talk about is the prevalence and statistics of child sexual abuse in the US. So there seems to be an upward trend in sexual abuse disclosures in the United States within the last decade. There's really, when looking at prevalence and statistics, like I said at the beginning, it can get a little murky, especially because we don't have that shared definition. But the statistics that are provided are from two different systems. So the first one is child advocacy centers, which we have on this slide here. And for those of you that aren't familiar with CACs, they are community-based multidisciplinary services for family affected by abuse, not just sexual abuse, but physical abuse, emotional abuse, witnessing domestic violence, as well as neglect. And their statistics are up on this slide here. And what I really want to highlight is that 2/3 of all of the cases CACs handled in 2019 were sexual abuse. So it is definitely more prevalent than the other areas of abuse, such as physical abuse, neglect, things like that. And the other part I want to highlight, because that also seems to be an area that people tend to miss, is that 25% of these cases involve another child. So that would mean that the perpetrator is the child as well as the victim. And then just briefly, so unfortunately, not all abuse cases go through CACs, although they try to handle as many of them as they can. So there are more broader statistics that are given by the CDC that have even higher numbers than this on the screen. But for the sake of this presentation, we wanted to highlight the ones from the CACs. Okay, so there are not one set of symptoms or behaviors diagnostic of child sexual abuse. However, research does suggest that there are common clinical characteristics and symptoms of children who have experienced sexual abuse, and they seem to fall in 4 distinct categories. So we have physical and medical symptoms, behavioral symptoms, emotional symptoms, and sexual symptoms. And it's also important to understand that a child may present with all of these symptoms, none of these symptoms, a combination. It kind of just depends and is individually, there isn't, like I said, one diagnostic criteria. So I'm going to go through and just highlight a couple of the symptoms in each category. So in the physical and medical symptoms, some of these can include pain during urination or bowel movements, wetting or soiling accidents unrelated to toilet training. And a lot of times this might happen almost as like a regression when they've already kind of stopped that wetting behavior because they've been toilet training, but they'll regress back. STDs, chronic stomach pain or headaches, as well as difficulties processing inner body signals. So whether that be change in heart rate, breath, feelings of hunger, pain, or temperature. In terms of emotional, you get kind of symptoms from every type of mood disorder. So you get depressive symptoms, you can have anxious symptoms, you could have post-traumatic stress symptoms. Some of these can include sadness, fatigue or decreased energy, social withdrawal, decreased eating habits, restlessness, hypervigilance, excessive worry, or difficulties concentrating. In the behavioral category, oftentimes we see aggressiveness towards parents or siblings, maybe even teachers in the school setting, hyperactivity, increased defiance, rebellion or runaway behavior, and then, like I mentioned earlier, regression to previously outgrown behaviors, whether that be like sucking a thumb or bedwetting or having wetting accidents during the day, things like that. And then the last category are sexual symptoms. So this could be things like talking inappropriately about sex, being preoccupied with sexual issues or topics, viewing pornography, as well as self-masturbation. So disclosure, the word disclosure refers to the process of a child coming out and telling either an adult or another child about the abuse that has occurred. The most important thing to know about disclosure is that it is an ongoing process and it is often delayed and gradual. So what research tells us is that majority of children do not tell in childhood. Specifically, most recent research studies suggest that disclosure rates are about 33% in typically developing children. I'll speak in a couple slides to the statistics more specific to children with developmental disabilities. But even still, majority of children do not tell. The average time between onset and disclosure is about 2 years. And when thinking about why kids do not tell, there can be many different reasons. Some of these include secrecy, helplessness, entrapment or accommodation, delayed or conflicted disclosures or retraction of disclosures even. And a lot of this has to do with kind of the power differential that's held with their perpetrator. And then another thing to point out, because if we're talking about why kids don't tell, we also want to talk about why kids do tell, right? And so a lot of this has to do with social, cognitive, and emotional factors. So a lot of times kids who are younger might not have the language skills to communicate to a caregiver or an adult that the abuse is going on, as well as they might not have the cognitive skills, which we'll also talk about later with developmental disabilities. They might have not just be aware that what's going on is wrong, but then once they get a little bit older, they might, start to have sexual conversations, like typically developing sexual conversations with their peers, and then realize, oh, wow, that happened to me. That wasn't right. And then they disclose. So that kind of is how that works. Okay, so now that we've kind of done a broad review of child sexual abuse, we are going to start talking about the intersection with kids with developmental disabilities. And throughout the rest of our presentation, we are going to be referring to a fictional case example in order to kind of help you all apply some of the things that we're talking about to a case. So just a brief overview of Theo. So he was diagnosed with a developmental disability at age 2. He currently is living with his mother, who is a single mom, and also lives with his mom's boyfriend, who has been in the home for 7 years, as well as his younger brother. Theo's suspected perpetrator is his mom's boyfriend, and the sexual abuse is allegedly occurred over the last 4 years. So that would have started when Theo was 5, right when he was entering kindergarten. And right around this time, mom reports that she saw an increase in behaviors, specifically like defiance, things of that sort. And when back then she thought that it was related more to the transition of starting kindergarten. And currently, mom is considering residential care for stabilization of Theo's behaviors. They've gotten progressively worse over the last couple of years. And there's been limited response to in-home care and other types of treatment. And another important thing to know is that he was diagnosed with ODD in addition to the developmental disability right around that kindergarten age when he was starting to develop some of those defiant symptoms. And then some of his other symptoms include increased aggression, irritability, low frustration tolerance. Problematic sexual behaviors also have started to appear in the last year, specifically masturbation, which mom is also really concerned about. And so we want you guys to keep this stuff in mind as we walk through. But like I said, we'll be referring back to the case as we present the rest of the slides too. So just a brief overview on developmental disabilities. So they are a diverse group of conditions due to impairments in physical, learning, language, or behavioral areas. They begin anytime during the developmental period, which is birth up to 22 years of age, and often last across the lifespan. So these are chronic disorders that stay with someone over time. And the most current statistics say that 15% of US children aged 3 to 17 have been diagnosed with a developmental disability, which is about 1 in 6 children. So it's really not as rare or uncommon as sometimes we think. And another thing to recognize is that they occur in all racial, ethnic, and socioeconomic groups. So this is just a word cloud, more of a pictorial representation of all of the different developmental disabilities. For the sake of this presentation, we just are talking about developmental disabilities in general, but I did want to include this just to give you all kind of a visual representation of all the different types that there are out there. So when we think about general areas of impairment in youth with developmental disabilities, there's really 3 broad categories. So there's cognitive impairments, communication impairments, as well as emotion dysregulation impairments. So some of the cognitive impairments may include difficulty with abstract and critical thinking, sequencing events, prioritizing, task breakdown, ambiguity, and they are more likely normally to have a concrete thought process. In terms of communicative impairments, a lot of times these kiddos have delays in both their receptive and expressive language, idiosyncratic speech, echolalia, poor social skills. They often engage in one-sided conversations or have difficulty engaging and responding to others. And they oftentimes lack those like social boundaries and social situations. And then the third category is emotion dysregulation. So these kiddos have difficulty identifying emotions in both themselves and in others. They have difficulties expressing emotions via facial gestures and verbal statements, as well as sensory sensitivity. They may be more impulsive, easily agitated, or more prone to anxiety or behavioral issues. And a lot of that has to do with them not having the proper coping skills to regulate their emotions. So instead, it comes out as acting out behaviors. And when we're thinking about our case of Theo, so his due to his developmental disability, his primary impairments include fixations. So he gets very fixated on a certain topic and kind of can't get out of it. He has very black and white thinking and is highly focused, again, on those areas of interest. In terms of communication, he has limited verbal skills. So although he's 9 years old, he currently has the vocabulary of a 5-year-old. So although he can talk, he provides limited details, and oftentimes his sequencing is off. And this will come up later, especially in the assessment process. Bethany will speak more to this, but that sequencing can the difficulty sequencing events can affect how kids are able to tell about abusive situations. And that is all with that one. Okay, so what do we know in terms of, youth with developmental disabilities who have experienced sexual abuse? Well, research suggests that they are 3 to 10 times more likely to experience sexual abuse than their typically developing peers. Furthermore, there's also decreased disclosure and investigatory rates. So in one research study, they found that 1 of every 30 cases of child sexual abuse was reported and investigated in children with developmental disabilities, as opposed to 1 in 5 in typically developing kids, which is honestly very concerning. And this increased vulnerability may be due to some of those impairments that I spoke about on the previous slide. So the cognitive, social, adaptive, as well as emotional impairments. However, it's important to recognize that these kiddos experience similar effects of the sexual abuse as children without developmental disabilities. However, they tend to experience them with a greater frequency, intensity, and duration. And then finally, another very important thing to understand is that the symptoms of child sexual abuse often are misattributed or overlap with their developmental disability and some of the impairments they may have due to that. So this creates, again, that kind of murky area and can make it very hard to assess and tease apart what is related to their developmental disability and if it is related to an abusive situation. So what are some of the risk factors for sexual abuse in youth with DD? Well, in general, just risk factors for typically developing kids. So perpetrators tend to prey on kids that have poor judgment, they lack gullibility, they're easy to obtain trust, inability to tell, and the likelihood that a victim will not be believed. They're all characteristics that perpetrators look for in potential victims. And all of these characteristics are increased in youth with DD. So right there off the bat, that makes them at an increased risk. But the three main kind of areas that are risk factors for these kiddos with developmental disabilities are their social isolation, their decreased knowledge, and their increased dependency. So in terms of social isolation, a lot of times these kiddos are isolated from resources, especially caregivers to report the abuse to. They're more likely to be placed in residential care facilities, and they're also more likely to be viewed negatively by society and labeled as bad because they are different. And these feelings of isolation or withdrawal due to these differences make them more vulnerable to manipulation due to their increased responsiveness to attention and affection. In terms of decreased knowledge, like I said before, they have cognitive and processing delays that can interfere with understanding what is happening in abusive situations or even realizing that the abusive situation is wrong. They are more likely to have poor judgment. And oftentimes, a big risk factor is that they have decreased knowledge, sexual knowledge. So there seems to be an assumption that both kids and adults with developmental disabilities are asexual and therefore do not need sexual education. But research suggests that this is 100% false. And however, that can create, again, the decreased knowledge piece. And then finally, the increased dependency, because they are trained to be compliant to authority figures. They're more likely to do what someone tells them to do. These kiddos are dependent on caregivers for longer periods of time, for more types of assistance than typically developing kids, which again creates that increased vulnerability. And in our case with Theo, he kind of, the risk factors that he kind of holds are definitely that social isolation piece. Mom spoke in the clinical intake how because his behaviors are gotten so out of hand, she doesn't like to take him out much in terms of like in the community with her to the grocery store. She is less likely to have him participate in social activities with other kids, extracurriculars. So he really only kind of gets those social pieces in the home with his mom, his brother, and then his mom's boyfriend, who's the perpetrator. And then, like I said, he is 9, but his verbal level is at the capacity of a 5-year-old. So he has that decreased language ability to be able to communicate about the abusive situation, and is likely to have decreased knowledge of sexual encounters and sexual behaviors, as well as that increased dependency. So as I said earlier, the symptoms are similar. So that slide that I went over, the physical, medical, emotional, behavioral, and sexual symptoms, all of those symptoms are also occur in children with developmental disabilities who have experienced sexual abuse. So I'm not going to go through all of those again. However, I do want to point out a couple reasons why the affective trauma may be increased in this population. So it might be due to a couple of things. So there's a predisposition towards emotional problems in kids with developmental disabilities, as I mentioned, as well as an impaired resiliency before the abuse occurs, which gives them limited resources to cope with these abusive situations. Additionally, they may have reduced protective factors that could lessen effects of child sexual abuse. As well as they may have the long-standing belief that, like I mentioned earlier, that people with developmental disabilities are asexual. So how could they have a sexual experience? How could sexual abuse happen to them if they're asexual? And all of this kind of increases that effect of the symptoms. And so now I'm going to hand it over to Bethany, who is going to talk about diagnostic considerations and things to know during assessment and the disclosure process.
Okay, thank you, Addie. So I'm going to go to the next slide. So when we think about the referral process, the assessment process, and treatment, we need to remember that oftentimes trauma is not the referral question or concern. So most children get referred for diagnostic clarification or support due to various emotional, mental, social, and behavioral symptoms. So some common problems for referral are included on this slide, and I'm just going to kind of quickly walk through them and elaborate on some that might be a little bit more complex or difficult to tease apart. So we see hyperactivity, aggressiveness. This may be towards self, towards others. Social withdrawal and isolation is a very common one. Depression symptoms, low mood, anxiety towards others, certain settings, separation anxiety from a caregiver, problematic sexualized behaviors, which Addie touched on in her slides and we'll touch on later. Dissociative experiences, so potentially saying, yeah, my kid seems to be daydreaming a lot during the day or kind of inattentive. Substance abuse, especially in older kids, running away from home, risk-taking behaviors, and inexplicable physical complaints. So Addie mentioned earlier, specifically chronic headaches, stomach aches, body pain that does not have a physical origin. And this is where, they may have been referred to a medical professional. Now they're getting referred to us because there's really no explanation physically. So unless trauma experiences are explored and asked about, it's very common that the sexual abuse experiences may go unreported, unnoticed, and continue to negatively impact a client's overall functioning. So if we look at our example of Theo, we see highlighted in blue some specific concerns that his mother brought up in the intake that could be a result from sexual abuse. So specifically, she reported increased aggression, low frustration tolerance, depressed mood, and problematic sexualized behaviors. Often with caregivers, we're given this very broad picture of functioning. And as we go through the process of assessment and diagnostic clarification, it's our job to piece together the different aspects of abuse, symptoms, and functioning to aid in our diagnosis, treatment, and recommendations moving forward. When it comes to the assessment process, to determine whether sexual abuse is present and then its effects, clinicians kind of have a threefold process to developing case formulation and treatment goals. So the first thing we want to consider is we need to assess trauma experiences and the symptoms present in the client in order to understand their connectedness as well as their unrelatedness, right? So not all symptoms may be due to a trauma experience, but we have to be able to connect them and kind of form a holistic picture. The second thing we want to look at is we want to assess for comorbidity or other impacts on clients' functioning and symptomatology. And this can be a very complicated web, which we're going to talk about later in different slides. The third thing we want to look at is we must assess the client's developmental level. And this is important to establishing rapport, assessing for trauma. So whether we use more play and nonverbal techniques, or we use more standard verbal processes in assessment and treatment. And it also helps us develop appropriate treatment goals that fit with their needs and as well as their developmental level. So if we look at our case here, right, we have some information that fills in some of these gaps. We know that Theo has suspected child sexual abuse that's occurred for the past 4 years. We also know that there's several symptoms that mom is talking about and presenting in the intake: aggression, that poor frustration tolerance, depressed mood, problematic sexualized behaviors, and these have been increasing since kindergarten, when the abuse began. We also see comorbidity. He has an ODD diagnosis along with his developmental disability. And we also see developmentally that although he's 9 years old, his language skills are not as developed as a typical 9-year-old. And so that's something we have to consider and take forward as we work with this specific client. So there can be challenges when assessing for trauma in youth with developmental disabilities that we have to be aware of when working to aid in diagnostic clarification as well as treatment. So for one, the symptoms of trauma and developmental disabilities may overlap, particularly in attentional, social, behavioral difficulties. So clinicians have to be very perceptive to observe when behaviors occur and what they're in reaction to in order to assess whether this is due to maybe a trauma experience of sexual abuse or whether it's due to the impact of the developmental disability, such as a change in schedule or routine. Since reporting of trauma by this population is unlikely, as Addie mentioned earlier, we also want to be aware of how much knowledge do caregivers have of the potential symptoms of trauma in youth with developmental disabilities so that they can aid in reporting and getting their child proper treatment. In addition, children with developmental disabilities tend to behave developmentally younger. So when working with very young children with developmental disabilities, it's very important that we slow down our speech, use simplistic language, and present one concept at a time. We may also supplement play and drawing materials in order to make related adaptations so that one, we don't overwhelm the client, but two, we increase their comprehension. As we include their interest, as we include more nonverbal ways of gathering information and building rapport, that can be really helpful in increasing what they get out of session, as well as what they're willing to disclose to us. Children with developmental disabilities may struggle with abstract thinking, sequencing events, and breaking down tasks, which Addie mentioned earlier. And specifically, the sequencing of events is going to be very important, both for collecting information as well as how we conduct our structure and our sessions, right? So being able to set a routine, set a structure will be very helpful as we work with individuals with developmental disabilities, but also we have to think about how can we gather proper information with potential gaps in their sequencing of events that have occurred to them. It's also important that because of the likelihood that the ability to communicate may be difficult, it's important to consider the involvement of parents and guardians, as well as school and daycare personnel in both the assessment and treatment process. So not only does this provide support for the client, but it also provides more third-party information that may be useful as we're gathering information. So now we're going to move into some diagnostic pieces. So child trauma can be complex to tease apart, as I mentioned earlier, and often children may be diagnosed with several other diagnoses, and trauma experiences may be left unaddressed. So we need to think both historically and presently when we're assessing for a diagnosis. So I've added some diagnoses here on the slide that are common, either comorbidly or diagnoses that may be diagnosed and trauma experiences left unaddressed. So I want to start with ADHD. So something that the literature points to is that as we have disruptions in our psychological functioning and mood, this can oftentimes influence our ability to concentrate and sustain our attention. And in addition, some reactions to traumatic stress may be perceived as impulsive or hyperactive in nature. I mentioned dissociative symptoms earlier, and these related to a sexual trauma may be perceived as general inattentiveness. So it's important that we dissect both the duration and onset of these different symptoms and behaviors. And this is where third-party information comes in to be a very vital resource, really to understand, were these symptoms present before the sexual abuse experience, or are they occurring as a result of maybe reacting to that stress due to the sexual abuse experience? It's important for professionals to know that individuals with developmental disabilities, such as autism spectrum disorder, that this inattention presentation could be due to overstimulation, lack of stimulation, or general boredom. We oftentimes hear that as well. When we look at anxiety disorders, to have comorbidity, we want to see those anxiety symptoms be unrelated to the traumatic incident, as well as rising above the diagnostic threshold that's in the DSM. Additionally, we see with some developmental disabilities that anxiety may be seen with large changes in routine and structure or the family dynamic, which may or may not be related to a trauma experience or a comorbid anxiety disorder. It could be due to developmental disability. So it's important to note that symptoms can overlap, but there can also be numerous underlying causes to an anxiety as well as a depression presentation, which I'm going to get into here in just a moment. So just like anxiety disorders, depressive disorders may or may not be preceded by a traumatic event. And here we're talking about sexual abuse specifically. So depression that is present in the absence of symptoms related directly to the trauma event may lead to a comorbid diagnosis. But again, we have to understand and tease apart what is potentially due to the trauma and what is due to another mood disruption. When it comes to ODD, as we mentioned earlier, a common referral question is related to children's perceived defiance and behavioral dysregulation. And so an important consideration here is whether the behaviors are a result of willful disobedience or the potential physiological distress associated with internal external cues to a trauma experience. So for Theo, right, this is tricky. He's been diagnosed with ODD. And as clinicians, we need to take a trauma-informed developmental and systematic approach to these symptoms. Oftentimes, children with developmental disabilities disclose using nonverbal behaviors, so we need to understand the root of the symptoms in order to properly diagnose. PTSD is on this slide because it is important to note that not every child or adolescent who experiences abuse will develop PTSD. So it's really important that we look at both the symptomatology and the inclusion criteria to understand whether they meet that diagnosis. And lastly, I'm going to talk about conceptualizing problematic sexualized behaviors in children, because oftentimes these are misunderstood and they don't fit neatly into a diagnostic criteria kind of box. So concerns with these behaviors arise, particularly when they occur frequently. They're initiated with strong feelings such as anxiety or anger. They cause potential harm to self or to others. They don't respond to typical parenting strategies such as discipline, which we see in Theo's case, or they involve aggression or force. So problematic sexualized behaviors are often seen in the literature as occurring due to a child feeling anxious or angry or reacting to a traumatic experience specifically to calm themselves down. It could also be due to a curiosity about sexual material or trying to imitate others, potentially those who are more developmentally mature. So a couple of consideration questions for professionals. And really, I've broken these down into 5 categories. So is the emotional, cognitive, and behavioral presentation of the client related to the incidence of trauma? Or is this presentation due to another stressor or disturbance or developmental difficulty? So we want to really understand the origin or the etiology of the symptoms. The second question, does the client meet criteria for a diagnosis, or are the symptoms below threshold? So we want to determine, is diagnosis even appropriate, or are these things we need to address in treatment but not give a diagnosis to? Is there the potential that the symptoms and experiences can be explained by one diagnosis or multiple? So understanding comorbidity, does it exist, or does one disorder explain the presentation? Has there been an interdisciplinary evaluation for child sexual abuse? So this interdisciplinary collaboration is really important. Have the child been interviewed by a social worker or case manager? Have they sought medical attention? Have they seen other psychological professionals? Understanding what information has been gathered will be important moving forward in treatment. And then lastly, what's been done to aid client in functional treatment? And what are the specific goals and needs of the client? So oftentimes we see clients who've seen other professionals. So we want to understand what's been done before to relieve some of the symptoms, as well as aid in functioning, as well as what are the current needs? What needs to be done? What goals are the parents or the client wanting to meet? We have to understand that in order to move forward. Some other specific questions we want to target. Specifically in the forensic realm of things, right? These children may be involved in the forensic setting because of the reporting of child sexual abuse. We want to understand how can we modify the forensic procedures to include more trauma and disability informed practices. So how can we both make these children feel comfortable to disclose, but also support them in their specific needs moving forward? And we also want to understand how can we address the effects of child sexual abuse when there's an absence of disclosure. And this is something that Dr. George is going to talk about later, is how do we address both communication as well as disclosure. So specifically looking at suggestions for interviewing. So for one, we want to emphasize the emotional and cognitive affect over specifically the content of a trauma experience. So this is important for building rapport. Of course, we're going to have to collect information, especially if we're reporting child sexual abuse. But when we're talking to clients, we want to emphasize how they feel. So we may say something like, I would like to talk to you now about how you feel and what has happened and what you think about it, because this is important to understand. So we really want to emphasize how they're feeling, what they're thinking, and not just the content, the specific details. Another piece is understanding a client's own language and their developmental level. So we might ask, what words or images may you use to describe what happened to you? We can also involve play and drawing into this, right? We may say, hey, can you draw me a picture of kind of how you would describe what happened to you, right? And we can use other language around that. But being able to put specific words to this is really important for normalizing their experience as well. Another important piece of information to gather is coping mechanisms, right? Particularly coping mechanisms during the abuse as well as after. So we may ask, what feelings from the abuse, when feelings from the abuse bother you, what do you try to do to help yourself feel better? We may also give certain options, right? We may say, hey, when kids are feeling maybe feeling bothered from their experience, sometimes they try to do things to feel better. I'm going to tell you some things kids might do, and you tell me whether or not you do those. So maybe giving options might help with some of that kids understanding, oh yeah, I do that. I watch TV, or I go outside and play to try to get my mind off of this. And so we want to understand that, because that's going to be very important moving forward with treatment. We also want to understand how a child views themselves in the world as a result of their traumatic experience. So we might ask something like, do you think that sexual abuse has happened to other kids? Or do you feel like this experience hasn't happened to anyone else? So understanding whether they feel alone and isolated, or whether they feel like, I do think this happens to other people. This can be good for support building, as well as normalizing the experience, but also helping us gather perceptions about self. We also want to build trust, and this can look very different, but we want to normalize both their own autonomy and choices in the session, as well as that the place is safe. And we set boundaries. And between the professional and the child, there's boundaries that both keep us safe, but also build healthy relationships. So lastly, we're going to talk about diversity considerations. So specifically, right, sexual abuse doesn't happen in a vacuum. There's a lot of cultural, gender, socioeconomic factors that relate to child sexual abuse occurring. I'm going to give a couple of quick statistics that I think are related back to our case of Theo that you might keep in mind as you work with different clients. So children who live in a single parent household that have a live-in partner are at the highest risk of sexual abuse. They're 20 times more likely to be the victims of child sexual abuse than children living in a parent with two parents or even just a single parent household. In addition, with social economic status, children in low SCS households are 3 times more likely to be identified as a victim of child sexual abuse. And so this is really important just to understand the different clients you may work with and the certain risk factors they may have. We look at disclosure, right? With children with developmental disabilities, this includes more than just verbal reflection. It oftentimes encompasses emotional and behavioral and nonverbal processes. So particularly, disclosing behaviors may look like temper tantrums, angry outbursts, clinginess, or avoidance of certain situations. So understanding how disclosure can look different and how it's a process is really important. Another consideration is differing levels of sexual educations and perceptions of what's appropriate and inappropriate. And so the differing levels of sexual education can influence a child's willingness to disclose, as well as their understanding about what is sexual abuse and what is not. So we really need that educational piece to help them understand what's appropriate and what's not. And Dr. George is going to go into that as well. Some gender differences, just to mention quickly. It's important to note that males with and without developmental disabilities are less likely to disclose sexual abuse and get support. So that's just something to think about moving forward when you work with potentially a male client who's having these aggressive and angry outbursts, and there might be even a suspicion that abuse has occurred. So being able to look into that and really assess that properly is important. And so now I'm going to turn it over to Dr. George to go over some intervention considerations when working with these individuals.
Thank you, Addie and Bethany, I appreciate you both for giving us this great comprehensive overview. So once we have confirmed, right, that Theo has been sexually abused, how do we intervene? Well, intervention-based studies, while they have been limited in number, have found that the following techniques are beneficial for individuals with cognitive disabilities. This includes TFCBT, EMDR, and play therapy. Studies such as Allen and colleagues in 2017 found that using CBT techniques actually resulted in lower scores after treatment, particularly with post-traumatic stress, dissociation, anxiety, anger, and depression. But first, let's actually take another step back and take a look at potential barriers for the evaluation and treatment of child sexual abuse. As you can imagine, there are obstacles that rise up when treating this population, and we each hold our own biases, and there are some widespread beliefs that the field and professionals may hold in general. And I'm going to address two of those here today. So the first is that, we have these problematic beliefs and attitudes, and some include that children with disabilities cannot accurately provide information regarding their experience. Another one is that children with disabilities are not affected by abuse. Children with disabilities are difficult to work with. And children with disabilities are unreliable witnesses. And these, of course, are all false. Research actually indicates that children with disabilities have the ability to provide accurate information, and more research is needed to inform professionals and improve child abuse evaluations. The second area is that children develop at different rates and stages, including physically, emotionally, and socially. While this is true, there are other areas that are often quite missed or not even considered. First is that they also develop sexually, which is often overlooked as a typical area of development. We overlook and neglect sexual development of children and adults with disabilities, especially those of us who are able-bodied. This may be directly associated with the beliefs and attitudes that a child's disability may prevent them from engaging in romantic and sexual relationships. The second is that problematic sexual behavior may be a result of child's sexual abuse. And problematic sexual behavior may also develop due to intellectual and developmental issues or other factors, such as the lack of appropriate sexual education for this population. So therefore, specialized evaluation and intervention should also include a physical examination and a full psychological assessment. So as professionals, we need to not only identify these problematic beliefs, but also educate others, as these attitudes can negatively impact interactions with these children. And it may also lead to unsupportive and less effective treatment and interventions. Which leads us to like the systems involved. A child with developmental disabilities with suspected child sexual abuse may interact with law enforcement, medical professionals, behavioral health, the court system, and others. So what are some of the system considerations that we need to take into account? Well, due to the various nuances and vulnerabilities of this population, each system would benefit from the development and implementation of training. For example, staff members, clinicians, other treatment team members should understand that children with disabilities may communicate their fear and distress through sexualized, externalizing, or challenging behaviors, especially those with limited verbal skills. Another recommendation is limiting the number of interviews, as this may create additional stress and confusion for the child. It also may lead the child to perceive that they are not believed, or maybe they're in trouble, and therefore they may avoid disclosure. And lastly, we recommend consistent communication between members of the child's treatment team, as this helps with creating a united, supportive culture and also leads to greater comprehensive care for the child. So Theo comes in to see you. So how do we approach safety and talk about safety? Well, several tools and suggestions include the body safety rules. So how do we teach children to keep their bodies safe and protected? The first is to identify parts of the body that are private and to use medical terms. These medical terms, include breasts, genitals, and buttocks. We use medical terms to ensure and encourage clear communication. So a while ago, there was a story in social media, and I'm not sure if it's true or not, but I think it's a really good demonstration of this, of how a young kindergartner kept telling her teacher that her uncle had licked her cookie. The teacher was a bit confused that this was an odd statement and just responded that she can get a new cookie. The young girl repeatedly went up to the teacher and shared that her uncle licked her cookie. So it was later discovered that the young child was being sexually abused, and the family's term to identify the vagina was cookie. So while she was disclosing the sexual abuse and had done so numerous times to her teacher, there was a delay in intervening and getting this child treatment because the medical terms were not taught or used in the household. The second is the clean and healthy rule. So who is allowed to touch and see you? Well, the clean and healthy rule states that it's only okay for parents and or other caregivers and guardians and the doctor to see and touch our body parts if it's to keep us clean and healthy. So examples of this include physical exams at medical offices, during bath time, helping to wipe during potty time, and so forth. Also remember that repetition is essential not only for this population, but children in general. So you want to encourage your parents to gently remind them to review this rule frequently, and to remind the child of the clean and healthy rule. So what about children who may not be able to fully verbalize what's happened? These were some recommendations from a fellow child forensic interviewer. If the child has limited verbal capacity, but is able to physically nod yes or no, such as Theo, right? Consider the following. So a conversation might start out with, Theo, please nod yes or no. Did anybody break the body safety rule or the clean and healthy rule, whatever it is that you choose to, use? You also want to determine who. So was it a child? Yes or no? Was it an adult? You also want to determine location. Was it in the classroom? Were you in the bathroom, home, or the bedroom? And then also determine the body part and ask about each private part specifically. Now, if you deem that there may have been sexual abuse or other physical harm, then stop and report immediately to the hotline and allow other professionals to get involved, including Child Protective Services and child forensic interviewers. Addie had mentioned earlier about child advocacy centers, which is a one-stop shop, and they provide medical, case management, mental health services. They also have a staff of child forensic interviewers who have specialized training. So why are child forensic interviewers important and very much needed? Well, first, children with limited verbal skills may be unable to report or struggle with providing enough detail of the event. This may also affect their ability to be seen as credible witnesses. Children with memory and information processing delays may have trouble with recalling specific details. Thus, these children should be interviewed as soon as possible versus months after the event in question. Working memory deficits may also reduce the amount of information that's encoded, and consequently, the amount of details a child can recall about an event may be limited as well. They found that in a study by Brown and colleagues in 2012 that children with severe cognitive disabilities provided disclosures with much less detail than those with mild to moderate cognitive disabilities. Next, children with a young mental age, especially those with severe intellectual disabilities, may struggle with discerning reality from fantasy. As mentioned before, Theo is 9, but he's more of a 4 or 5-year-old. And so therefore, his disclosure may include both fictional and factual information. Lastly, children with disabilities may find it difficult to differentiate between healthy and unhealthy social practices. This may be due to a lack of sexual education and difficulty with being able to identify acts of sexual abuse. Thus, child forensic interviewers can help assist and navigate through some of these factors to help elicit information about the abuse from the child. So, what are some considerations for you as a mental health professional? Well, first, as mental health professionals, right, we are able to provide consultation for interviewers, CPS workers, and teachers, police officers, and so forth. And a major consideration is that they may need to adapt the interviewing methods based on the child's specific needs. Of course, each child is different, but here are some general considerations to help with the process. The first is to have a child-friendly room. Also consider for children who struggle with sensory overload. Perhaps you want to suggest decreasing the amount of stimulation environment by lowering the lighting, using sound canceling headphones, especially in the waiting room, and perhaps using weighted blankets. Another suggestion is rapport building with the interviewer, including music and games prior to the interview, which can also help reduce anxiety. It also enables the professional to become familiar with the child's strengths and limitations regarding communication. And so if they do meet with a child with developmental disabilities and note that, Theo, right, is 9 years old, but he's functioning more at a preschool or kindergarten level, then they can then take that into consideration and change the vocabulary and the jargon that they use while engaging with Theo. Lastly, there's some online considerations, right? So who is in the home, who is around, consider, if there are any connection issues, do other arrangements or supports need to be available to engage the child and to keep them safe, such as closed captioning or sign language interpreter. Also, as Bethany had mentioned, even just the use of like coloring. And so can you use a whiteboard in Zoom to have the child like color or draw you a picture. Other considerations also include effective questioning techniques for this population. So the first is using free recall questions. So they found that the reports of children with disabilities who were questioned using free recall are usually longer. Their reports are usually more detailed, less suggestible, and more accurate when compared to the use of closed-ended questions. So some examples might be, child or Theo, tell me everything you remember. Theo, what happened next? Tell me more. We also suggest the use of closed-ended questions, or to use them, with caution. Now, this is not to say that you absolutely cannot use a closed-ended question, as they may be helpful in clarifying information, but we do strongly suggest that you use closed-ended questions with caution. This is because the child may unintentionally be manipulated into choosing a specific answer, or they may result in the omission of important information. Our last suggestion is to avoid using complex questions. So as a therapist, what do we need to specifically consider in clinical treatment? Well, first, there's another myth that if a child has developmental disabilities, they may not or will not benefit from therapy. The fact is that children with developmental disabilities will greatly benefit from therapy. Please note that progress and stability may take longer to achieve, but once they are obtained, these changes are typically sustained long-term. So from an advocacy standpoint, as clinicians, we want to ensure that children with disabilities are not overlooked, and that we provide psychoeducation to the family, caseworker, and other professionals involved in the case. Other therapy adaptations to consider when working with a child in your office is to slow the rate of your speech. You want to ensure that you use understandable terms for them and phrases that are developmentally appropriate for the child's cognitive abilities. Engage in frequent pauses and repetition to increase comprehension of the information and skills. You might sound like a broken record at times, and that is okay. Repetition is key. And you want to also utilize various learning methods to meet the needs of the client, such as videos, role plays, pictures, activity-based learning, modeling, feedback, and reinforcement. Also remember to use those free recall questions as well. And this kind of brings us to the end of our presentation, but just also wanted to provide you with some resources. So you'll receive a handout. And so this first is just a video on child advocacy centers it's a 1-minute video that provides a brief overview of what CACs are and how to use them. The next are, clinician resources. So we have a couple PDFs, a webinar on COVID-19 and CACs, books, and a resource guide. These are really great videos. We have 2 here on how to talk with kids about sexual abuse, but also what to do and say right away when a child has disclosed sexual abuse. And this is perfect for not only clinicians, but also parents and teachers as well. Here are some specific resources for parents about preventing child sexual abuse, how to have those conversations with children of all ages, how to reduce vulnerability, and this article about a parent about how she taught her child with special needs about consent. And then here are some resources for teachers about child sexual abuse, how they can also prevent child sexual abuse within the school and protecting children. So thank you for your time today and for listening to our talk. We hope that you enjoyed it, and thank you. Take care.
Thank you, Dr. George, Ms. Cooper, and Ms. Jeffs for sharing your time and knowledge with us. Do you have a question you'd like to ask the presenters? No problem. As part of our OPA 2021 convention, individual live virtual Q&A sessions have been scheduled for each workshop. All you need to do is mark your calendars and plan to join us virtually on the afternoon of Wednesday, April 21st, 2021, from 1 to 1:45 p.m. The Q&A session will be recorded and available for those who opt to view this webinar after April 2021. To receive CE credit for this webinar, please reference the document you received when you purchased this session. Use the links in the document to complete both the online webinar quiz and the evaluation form to receive credit. CE credit will only be given if a score of 80% or higher is achieved on the quiz. Should you have any questions regarding today's educational program or the CE process, please call the OPA office at 614-224-0034. Thank you again to our presenters and to our attendees for choosing OPA to meet your continuing education needs. This concludes today's educational program.